Hello, everybody. This is Lisa Johnson from Everbridge. Welcome to today's webinar, Patient Evacuation During a Hurricane with Bob Mckee. I will be your moderator today. I am the Senior Program Manager for Healthcare, and I've worked in the healthcare industry for a little over 4 years, and I've been at Everbridge for the past year and a half. I'm going to sort of briefly introduce Bob. I know a lot of you have been on webinars with him before, and we also want to give a shout out to Leonard Dionorine, who was planning on being with us today, but unfortunately the storms that have been plaguing the Atlantic Ocean this year have pulled him away. So Bob was graciously able to step in on his behalf. He has quite a bit of experience with hurricane management, doing emergency preparedness in Texas. We'll tend to do that to a person. I'll let him introduce a couple of stories for you. But welcome, Bob. Thank you so much for coming today.
Thank you.
And I just want to cover, why are we here? And obviously we're here because preparedness matters, and all of these pictures that are up are from the last 6 weeks of all of the hurricanes that have gone by. And they're just a representative sample of all the things you have to think about as an emergency responder. Is there going to be an evacuation? Are there going to be cars on the road? If they are, can your employees get to the hospital? How are you going to help them be there to help patients that are left behind? You're going to need all kinds of supplies, from cots to medical supplies. How are you going to have those in place and ready to go? And then if you do need to do a patient evacuation like that bottom left corner, that's a NICU evacuation that happened during Hurricane Harvey, do you have all the systems in place? Do you have the high-level clinical personnel? Do you have the equipment? Do you have, in this case, a plane or an ambulance or something to get them to a safer location? And then the last picture on the bottom right, I just want to give a shout-out to Team Rubicon. They are... they work off of our Everbridge platform. We donate that to them, and they have been an amazing force for all of the hurricanes that have been happening this season. They are primarily veterans that have been trained in disaster response, and they go in to the worst areas and do all sorts of relief work. If anybody who's listening today is still in an area that needs assistance, by all means call us and let us know, and we can connect you with Team Rubicon. So with that, Bob, I'm going to turn it over to you. Let me give you the slides.
All right. Well, thank you for working through the technicalities with us. We certainly appreciate everyone's time. I'd like to echo what Lisa offered and really give credit to Leonard for his time and his commitment to educating all of us on the experience that he has had within the hospital evacuation realm. While he was literally on the run, I was able to speak with him and get an idea of his context. And so, again, we're certainly thinking about him and his colleagues. But I'm certainly honored to step in. As Lisa said, many of you may have been a part of previous webinars. We work very closely with Everbridge here at Boston University School of Medicine, where I'm based in the Healthcare Emergency Management Program. But as we all have those little-known facts when we do a roundtable introduction, one of the little-known facts is I do many other things, and in my past, before entering into higher education, I was an emergency responder, a firefighter paramedic, as well as an emergency manager, and finally the director of emergency response and rescue for the state of Texas. So for a perspective, I listed a number of the significant storms since 2002. The spaghetti map that shows behind are all of those tropical cyclones from 1851 all the way through 2012. But to give you a little bit of background from my experience, all of those hurricanes listed up to this particular year, I have been involved in, I've responded to, either at the tactical rescue level or later into Hurricane Ike, Matthew, more in a strategic perspective. So again, what I'd like to give to you today are those experiences, again, that we've culminated and we move from here. So as you think about this subject, and I'm sure many of you were interested when you saw evacuating hospitals during a hurricane. Wow, that sounds amazing. I offer up a few pictures through many of the hurricanes, again, most recently this very active season, in essentially those items that captivate what's behind a hurricane. While we have so many technologies that show us the hurricane, it's on its way in, we get all of these watches and warnings, and we have incredible mapping and modeling tools. At the end of the day, it's still about, the individual. It's still about the tragedy that occurs, and we can prepare as individuals, we can prepare as organizations, as local entities or state entities, but at the end of the day, it's really still Mother Nature against man. And so the personal aspect of this is what we need to be reminded of on a regular basis, to say, hey, this is a real event, this is important to us, and particularly in the context, if we're evacuating patients, special needs individuals, they're already at a point, maybe not 100%, so how can we make that as safe and appropriate as possible? This is a picture from NOAA of 3 storms, a matter of really not even 2 weeks, just under 2 weeks, of hurricanes Irma, Jose, and then Katia on the left-hand side of the screen, all on the same screen, same visibility within the Gulf and Atlantic theaters. It's certainly a relatively busy season. The previous season that had storms from the list that would compare to this year was 2008. So we've had 8 years of peace and quiet, knock wood, and the hurricane season isn't over until November 1st. So we are by no means free and clear. We're by no means done as we continue to see the potential for further storms. What we should do is take this as an opportunity to plan, to assess our plans, to exercise, and to think about what in fact we should be doing. The objectives for today are to look at 3 levels of evacuation decisions and activities to determine what in fact means evacuation. We all have to start from the same definition, and if we're not on the same definition, it's difficult to discuss that. Talk about 5 different evacuation scales as an example. List alternatives to evacuation. Sometimes evacuation may not be the best choice. Describe 3 different types of evacuation, the trigger events and event sequences of an evacuation. List the issues with evacuation timing. This is something that is evolutionary. We need to discuss the Hospital Incident Command System, which many of you are familiar with, and we'll review that. And then lastly, to describe the technical operations that we can certainly employ for a successful facility evacuation. So again, as we always try to do with the webinars, is to ensure that you take away something today. So I'll circle back to these objectives so that you're actually going away with something, asking the right questions of the right people, and trying to implement change where necessary or evaluate your current systems. So looking at the evacuation decisions and activities, they're obviously at 3 levels: a strategic, a tactical, and a task level. Kind of sounds a bit like Management 101, project management, leadership, but it absolutely plays an important part of the evacuation decisions. Understanding the direction and the goals and the path forward is our strategic level decision making. This occurs within the hospital command center. All of the information available to the decision makers has been provided, particularly with hurricanes. What is the forecast of the landfall? Upon landfall, are we going to see a storm stall out like we did with Harvey versus a very powerful storm in Irma that very quickly moves on. Those are two different scenarios. While the storms themselves are certainly dangerous, it's the ongoing impact that may lead our strategic decision for an evacuation. The tactical decisions are those short duration activities or the operations that allow us to implement the strategic goals. So the decision making that needs to happen at the section, group, or unit level using our incident command terminology. And then our third level is the tasks which need to occur, the assignment which is underneath each of those tactical objectives. What do we need to do to carry out the tactical objective, which then supports the strategic imperative of our evacuation decision making? So, definition, evacuation, relocating patients, staff, visitors, and operations from an area of high risk to an area of low risk. If we were to poll the group, we would probably have modifiers to what an evacuation is, but in its most basic pretense, what we're trying to do is to move people from an area of potential harm or risk to an area of less harm, less risk. That includes an immediate evacuation area that talks about horizontal evacuation, vertical evacuation, building evacuation, or your entire campus evacuation. Again, making sure definition is clear for all of us. If we refer to horizontal evacuation, we're moving from one area of the same floor to another. So we're moving horizontal in nature. When we're talking about vertical, we're evacuating the 4th floor to the 2nd floor, or vice versa, the 2nd floor to a higher floor due to flooding, where we may go to the 5th floor. So again, these are scopes within our evacuation. What are some alternatives to evacuation? You may have heard throughout your training and your plans, a shelter in place. A shelter in place can be an alternative whereby there's an event, the public safety, the fire, the police, emergency medical are dealing with a chemical spill, or they're dealing with a chlorine leak that is near the hospital or near the medical campus. In doing so, they make the decision, do we need to evacuate due to the plume modeling, the direction, the wind direction and speed, the impacts of the chemical product that are leaking, or can we shelter in place? Can we stay where we are? Can we isolate our HVAC systems if necessary? And can we stay where we are? Again, as decision makers within the healthcare space, shelter in place has some of its own challenges, but given the choice of evacuating a hospital or sheltering in place is at the surface a much more positive experience because we're not moving patients, we're not taking and assuming those risks. So again, shelter in place is an opportunity. Alternatives as well, or we can add resources. So rather than evacuating, can we add in additional staff, additional resources to support us? Can we do a partial relocation? So if we have that scenario that I mentioned where we have a chlorine leak, can we isolate the west end of a particular building or of the hospital rather than an entire evacuation? Can we establish a safety buffer zone where, again, not only do we do that partial evacuation, but we have some space between us, our patients, our facility, and the event, or we alter the standard of care where we move into an acute treatment versus that long-term sustained treatment, and do we get into patient transfers, for instance, of more complex care, and we focus on the acute care. So the types of evacuation, again, back to our theory of threes: emergent, we've got to do it. We've got to do it now. We don't have time to discuss it. We have imminent circumstances. This is, if you will, a worst-case scenario because the pressure's on. But on the same token, it's obviously red alert, all hands on deck. This is what needs to happen. Urgent, okay, we've made the decision to evacuate. The storm has changed courses. It's coming in and it's going to impact us, no questions asked. In this case, at an urgent level, we've got several hours to set up and execute it. We've got the opportunity to anticipate some of the developments that may occur. We've got an opportunity to plan and continue to discuss. So certainly a much better scenario for us. And then the third type of evacuation, a planned evacuation, where we can actually schedule this. Okay, without any certainty, the Weather Service is saying the storm is coming in on us. It's going to be here Wednesday at 2 o'clock in the afternoon. We've made the decision to evacuate. As such, we're going to implement our time window, and we know for a fact what we're doing. And a planned schedule is, again, a best case scenario. What are some of the trigger events? Some of those emergent themes may be fires, or again, as I mentioned, hazardous materials releases. Certainly we're talking about hurricanes today, but we have tornadoes and earthquakes and floods and all other types of security issues. Certainly everyone is doing planning with active shooter drills, and we always look at the infrastructure issues. Within a hurricane, one of the things that's so complex, and as we look at preparing and using exercises in that preparedness, hurricanes often come up where appropriate, obviously, unless we're in the middle of the United States. But hurricanes come up because they pose a very unique hazard. They have winds. Again, the winds can be anywhere from 40 miles an hour all the way up to 150 miles an hour. But they also spawn tornadoes. So we can have a hurricane and we can have 4 tornadoes with all of the varying wind directions. We can have storm surge. So we immediately have static flooding, as we saw in the pictures for Hurricane Harvey. Water everywhere. Really the only way to operate is by boat. And then we can also have heavy rainfall, which again was in Harvey, but we saw that in Irma, and unfortunately in Puerto Rico, as we've seen Maria's impact. You know, not only was there extreme damage due to the winds, but everything just looks like a muddy mess due to the massive amounts of rainfall that occurred. So these are trigger events, and with these trigger events, we need to parallel those to our decision making. We need to rank them, whether they're emergent, whether they're planned events, as we discussed previously. We've got event consequences that always occur. We can lose a municipal water supply, we can lose electricity, natural gas, all of our utilities. We may be in a situation where we can't secure the facility, either due to some of those impacting items. There may be structural damage that we just physically can't do that, or flooding. And in that particular case, it's an unsafe situation. So what we need to look at is, while we're evacuating, if we've made that decision, there are consequences to those decisions, not just the obvious, most important, of patient care. Evacuation timing. One of the questions that I get asked a lot, having been involved with a number of storms in Texas, is, for instance, during Hurricane Harvey, why didn't Houston evacuate? That's a question that I still get on a very regular basis. It all comes down to timing. And what I've explained is, without getting into the complexities of who makes what decision at the local and county level, there is a timing window. And based upon the information that decision makers have, that decision needs to be made at an appropriate time. If you're outside of that time window, it's almost impossible, if not impossible, to be able to effectively and safely evacuate. So you're better off back to the shelter in place, or you just can't make that decision. It's too late. So the timing of evacuations really comes into play. If we evacuate too soon, we may be making decisions that aren't necessary. If we decide that the storm is 4 days out, The decision makers, the senior leadership comes to the tactical team and says, we're going to evacuate tomorrow. Well, tomorrow is supposed to be 70 degrees and sunny. Wait a minute, the storm's not here yet. One could argue, hey, that's a bit early. Again, as I mentioned in the Harvey example, if we evacuate too soon, we can actually elicit patient and staff injuries. So as with a hurricane, the order to evacuate, there are deaths reported in previous hurricane evacuations due to the evacuation, not the storm. So there is a very difficult balance, a fulcrum that has to be maintained. And then certainly the unnecessary business interruption. So if we evacuate too soon, and again, it's unnecessary, we have a big problem on our hands. Now, conversely, if we evacuate too late, the public is evacuating, the roads are much like the picture that Lisa mentioned on the introduction. Basically, our roadways turn into parking lots. So we couldn't move about if we choose to move about. We also could be impacted by the hazard that we're trying to avoid. So as with the picture in this slide, gosh, this is the way that I'm going to send my buses and my ambulances. Wait a second, it's now flooded. Or contraflow has been established, and those that live in a hurricane evacuation zone understand what that means, and that means that all roads turn opposite and all roads flow contra to the typical direction, so you can't get to where you need to be as you would any other day. Additionally, mass transit and public safety may be committed to other emergencies, so your support networks go down. So the timing of evacuations is key. So again, understanding that, looking that in your plans, building it into some of your exercises is very critical. And again, using the most current events as an example will help us. Many of you have been through the Hospital Incident Command training. Again, so that those that haven't, it's important to discuss the Incident Command framework, because this is the way that all of the entities around us at the hospital are operating. So we at the hospital level, if we're not already, we should be considering this type of system. We have an incident commander who is the person that's responsible for the event. They are the senior leader, or they could be a unified command where it's a group of senior leaders that are making the best decisions based upon the information they have available. There are support positions that work with the incident commander, a liaison officer working with other agencies and other entities, a safety officer to make sure that if we're evacuating our hospital, for instance, who's going to take care of all of the gases, the oxygen and other gases that we're going to use to make sure that we don't have supplemental problems, not only as a hospital, but as a community. We're going to have an information officer that supports the incident and the incident commander. Somebody has to talk to the media. The media is going to want to know, what are you doing? Why are you doing it? Who made this decision? Where are you taking the patients? And then the media is obviously going to be receiving phone calls from family members who are going to be saying, XYZ hospital is evacuating, no one's contacted me, I don't know where my mother's going, I don't know where my aunt's going. So the information officer has to maintain appropriate contact, not only with the media, but all public information sources, as well as the social media that we deal with today. And then the medical technical specialists that are going to be essentially dictating the way in which patients are dealt with, or if there's follow-up triage, or the specific medical levels of decision making. And then the functional areas of our incident management chart, the logistics, everything to do with supplies, resources, people, things, all of those important items in enabling us to do what we do. the planning section that's taking in the information that's being provided by the National Weather Service and other entities and providing that to the decision makers to make the best decisions. The finance section, someone has to pay the bills. We need to be tracking this early, particularly if we get into a declared event at the state or the federal level, because funding will be available to then supplement those costs at some level that have occurred. We still have employees. We have to deal with overtime. We have to deal with other issues, and that all has to be documented within the finance section. And then finally, the operations section, where the tactics and tasks occur. So we're carrying out an evacuation. The operations section is going to have a number of branches that then execute those particular objectives. We're going to talk more specifically, as it pertains to the subject of the webinar, hospital evacuation. We're going to talk about the evacuation branch director. So the evacuation branch director would be underneath the operations section, and they would have the responsibility for any horizontal movement, patient tracking and accountability, vertical movement, patient holding areas, and patient loading. The evacuation branch director would then have those functional areas that I just mentioned to you, so that there was a task level supervision, but also information sharing at those levels. So rather than worrying about everything all at once, we have leads that are focusing particularly on the patient holding area. So we've gotten the patients to where they need to be. They're in a holding area. Now we're just waiting for additional ambulances, or we're waiting for medical buses, or whatever that transportation is going to look like as we evacuate the hospital. The Evacuation Operations Center is where all of this collaboration, all of this communication should occur. This may not necessarily be a boardroom or a conference room. This may be an ad hoc area where we pull a couple of desks together at the corner end of a hallway. So it doesn't necessarily have to be a posh environment. It just has to be a functional area. It should be central, and it should be in an area that's accessible. It should be away from the overall hospital command center, because again, the hospital command center is looking at the strategy. The evacuation operations center is working on our tactical objectives and tasks. The evacuation operations center should have access to floor plans, to the stacking plans, to communications equipment so that we can communicate, and certainly be unified in operation with the fire department, the emergency medical services, and the hospital staff. The assigned work is going to be in a team structure, so that teams are working together of at least 2 to 3 people. 3 is really the ideal number when we have that staffing available. Initially, we've made an emergent decision, for example. We may have what we have available. However, we can supplement that as we request additional staff, and that would be filled by our logistics section. As we make the preparation to evacuate, we need to assess the patient's mobility level. We need to determine if, in fact, the patient can be discharged. Are they at or near discharge? We work with the medical technical branch who can assess, and so if we can remove people that don't need to be transported or evacuated, then that certainly helps us in the long run. We need to early and often and continually confirm the patient's identity. We need to use the information that we have, particularly as we deal with infants and pediatrics. We need to place the babies and the mothers together when possible. We need to prepare a document pouch for each patient. I'll talk a little bit more in detail about that. And then, where appropriate, we need to convert IVs to saline blocks so that, again, if we just have an IV that's a keep open, we're not doing any specific therapy, then let's go to the saline lock so that we just don't have all that extra entanglement potential that exists with the IV and the IV line. Prepare our portable oxygen equipment so that if we need to go off of the inline oxygen and we need to go to portable oxygen, that we have the correct number of tanks and cannulas, masks, etc. that we need. And we certainly need to ongoing brief and communicate with family members. There's going to be fear involved of not only, yes, we have an impending storm, it looks bad, but now I have a loved one that's being evacuated. So essentially total loss of control may exist, and so we need to involve and inform the family members where possible. So who goes first? We move the patients that are closest to the hazard first. So when we talked about some of the alternatives to evacuation, we looked at isolating. So if we have, for instance, an impending flood, that we've got an hour, and when we know that we're going to have flood waters, so we've made that decision to activate, certainly people on the ground floor and first floor are going to be our priorities. The upper floors are going to be okay for a shorter period of time, depending on the level of water, but we know in that situation we're going to focus on that ground floor, first floor. How can we move the greatest number of patients in the fastest way possible? So this speaks to the level of acuity. If we can move ambulatory, well-acute patients, let's do so. We may not necessarily need an ambulance for each and every person. Is there a way that we can bus those patients and move them away more quickly, and, if you will, in the form of a volume? What we're essentially doing is we're moving the patients that are easiest to move first, and then we're going to work into the more complex patients. Why are we doing that? We're doing that for a number of reasons. One, it's a volume business in evacuation, but two, as we start to evacuate, the practicality of this, the real world of this is we have to hone our process. We have plans, we've exercised it, hopefully in the best case, many times, but actually doing it is a different story. So if we're moving the patients that are able to be moved the easiest first, it's giving us a chance to practice. And that in and of itself will then allow us to focus more clearly on the harder patients who have more than likely a different level of acuity or certainly a higher need of care. We want to move the patients that are closest to the exits first and then work furthest. Again, this is the funnel effect. This alleviates any type of a bottleneck. That's how evacuations of communities work. We also want to move patients with the best mobility, and we want to ensure the lowest clinical severity first. So let's talk about patient tagging. Certainly with respect to triage, most of us have had some experience with triage tagging and the various levels. If we have tags available to us, we'll talk about evacuation tagging. That's great. But again, one of the important points that Leonard brought forward in his suggestion of many of these tips and tricks is let's keep it simple. The colored tape that you see here on the slide is available at all kinds of home stores, building stores, almost readily available to anywhere that you might see. So first, the access to this, if we don't have a stock already, but then in that emergency case of, oh my gosh, I need to buy something, it might be a tag, it might be tape, but essentially this suggested tagging system allows us to look at ambulatory, wheelchair-bound, non-ambulatory, behavioral health, and discharge patients. So again, a takeaway that if you don't have a system, this may be something to look at, and certainly something that's low cost but easily accessible. There are commercial evacuation tags that are available that are very similar to triage tags where you have terrible sections that actually peel off. You've got markings. Again, these may be something that you have in your kit. More than likely, if you don't, and you're in an emergent evacuation system, you're probably not going to have time to pick these up. So obviously the previous suggestion of the colored tape, but there are other systems that as you look at your plans now through this webinar and after, you can decide what's best for you and your institution. I mentioned earlier the document pouches. Document pouches can be something as pictured, where we can purchase these, we can have them in a kit. It can also be Ziploc bags. It can also be the paperwork with saran wrap so that we have some waterproofing. Obviously, creativity reigns when we need to make those decisions. But in that document pouch, we need to make sure that the patient's name is there, any of the medical records that are appropriate, respecting that a lot of us are using electronic medical records. There has to be a way of being able to track those things that are relevant to each patient. So in your plan, how are you going to do that? How are we looking at medication records, care plans, any of the discharge forms, and certainly the family contact information for additional information. So the document pouch allows us to, in one place, have the viable information, the vital information relative to that patient with that patient. Medications and other information need to be in the bag. We need to, again, have the patient label, the medical sequence number, the patient ID, medications, as I mentioned. All of these unique items can certainly go within the document bags. Another tip and trick is to consider that all rooms may not necessarily be visually cleared from a wide look, but as we do clear these rooms, is having some stickers that we can just place on the door jamb that says room clear. One of the observations that is made usually with most evacuation scenarios is the chaos, or the fact that we're always kind of going back over. So I checked that room. Oh, well, I thought I checked that room. You know, we want to be certain. We certainly want to be complete about what we're doing in that evacuation phase. So let's look at ways that are just simple and able to help us. This is a great sticker. It's very visible in its color, and it says room clear. But if that doesn't work, we can certainly use the colored tape. We can use duct tape. We can use masking tape. But again, in your plans, and as you consider these things, please put this into play. So let's talk about movement tips and tricks and ideas. The horizontal movements, so we're moving patients from the west end of the second floor to the east end, as an example. We've got, again, all the scenarios can certainly be different, but the patient is on a mattress. We've got padding. This depicts an area where we're able to secure the patient, and with simple mechanical advantage, one, two, or three people can do a lot for one patient. We talked earlier, the horizontal movement teams are typically 2 to 4 people. There should be a leader that's essentially organizing these things. We should have a number of horizontal movement teams. So, right, we're going to organize you. You guys are horizontal movement number 1. You're number 2. You're number 3. And then as the team leads make the assignments, okay, 3, I want you to go to room 203, and then I want you to go to room 205, and so we can have some organization. We're going to move from room to room or into that holding area, but we're not going to then extend out into a vertical evacuation. We're going to talk about that in a little bit. We're moving from our area to another area. In our ICS structure, the horizontal movement teams are going to work within the evacuation group supervisor or the group director, who is then reporting to the branch director. Vertical movement teams, we need a few more people, so 3 to 5. These are hybrid teams, so they may not just be nurses or technicians. This may be a hybrid group where we include the fire and EMS, for instance, to give us some extra skill sets. Again, we're still going to have that leader. We need to assess the number of teams that we need and use those. And then we need to assign an exit. One of the other tips and tricks that we wanted to pass on to you is that through a number of exercises, it's been determined that essentially 3 floors is the best case scenario. So if we're on a vertical movement team together, the exercises have shown that if we move 3 floors and then pass off to an additional vertical movement team, if they have 3 more to go, if we really get beyond that 3-floor limit, we're challenging ourselves physically, and in some cases then we can make mistakes or we can run into difficulties. So we want to back up the vertical movement teams by just saying you have a 3-floor limit, and beyond that we'll hand it off to someone else. Again, the vertical movement teams are going to report to the evacuation group supervisor or the evacuation branch director. Stairwell management, we need to be considerate of stairwell doors, the name or the number. I'm sure you would agree with me that all stairwells look the same, particularly during an emergency. So we need to pay attention to the numbering sequence, North Hallway 1. On the building plans, that's identified. That means something. But essentially, if we're going from one area to another area, it can get confusing, particularly if we add in the chaos of hurry up, the hurricane's coming, hurry up, hurry up, hurry up. We want to label the exits, roof, lobby, outside, so that we actually know where we're going. If that's not a permanent label, then we use our ad hoc system of tape, and we write on it, and we put the tape on so that we know, hey, the lobby is our patient staging area. So we're taking the people down the vertical movement. We're doing 3 floors at a time, and we're taking everyone to the east lobby. From there, they'll be further assessed and transported. This works the same if we're going up stairwells or going down stairwells. So I'm sure many of you are thinking, well, gosh, Bob's talking a lot about stairwells. Man, my hospital's got a bunch of elevators. What we're assuming is the elevators are off limits. We certainly drill that with our fire drills. In this particular case, we're planning for the worst case scenario and hoping for the best. So typically during a fire, we say the elevators are off limits because of the fire spread capability. During an evacuation for a hurricane, it may be that they're prohibited. It may be that they're being used by the fire and rescue personnel that are coming in and out. However, that's a decision that the command center, the decision makers, are going to make. Can we use the elevators? We don't have any water damage yet. We don't have an electrical hazard, so we can use the elevators. That's a decision that needs to be made, and in your plan, that would be outlined for what is the checklist to make that decision. So we may, in fact, be able to move patients by elevator. However, in reality, are we going to be able to move the volume of patients through elevators that we can through stairs? So I would pose that to you to say, really, the answer to this question is, if we can use the elevator, the answer is both. We're going to use the elevator and we're going to use the stairs. We have to be concerned with the fact, are we on generator power? Do we have power at all? And again, as I mentioned previously, is if in fact there is a need for the emergency rescue crews to be moving around, or even the emergency team within the hospital moving around, they may need the elevators for quicker access. And it may be a best practice that if you're using the elevators, you may have an elevator operator. So you may designate someone that's operating that elevator so that you have consistency in, I'm going on at the 4th floor and I'm going to the lobby. And then that person can, with the override key, can very quickly get back to the 4th floor, take the next patient to the lobby, et cetera, et cetera. Mentioning the patient holding areas in our lobby example, the temporary location is a place that we're going to care for the patients before they're either returned to their room or they're moved to a loading area for evacuation out of the building. Again, we can do that via ambulances. We can do that via buses if they're ambulatory patients, standard school buses, or we could use patient buses if we have those available and you've exercised on that. Supplies and resources are vital in this particular case. Again, making sure that we have portable oxygen systems. We may need cardiac monitors. We may need other types of support equipment that are relative to infusion pumps, portable suction. We may need to have, obviously, our code kits for our bag valve masks, etc., available. So thinking about this in a portable sense is very different than the nice package system that we typically work with day in and day out. We certainly are going to need some general medical supplies, gloves, dressing, bandages, waste bags, sharps containers. How, in fact, are we doing that? Again, we get lulled into the ease of the facility infrastructure, but if we take that and turn it into a portable system, it's certainly a different set of challenges. And what can we do to keep the patient comfort and privacy still of concern? Do we have water? Do we have the availability of ice? Do we have extra blankets? Again, how can we keep the patient as comfortable as possible? We may be evacuating the day ahead of a storm. It may be 90 degrees outside and the sun may be shining. So do we have some sort of eyeglasses or sunshades, the disposable eye shades that we all use from the optometrist when we have our eyes dilated? These things are all packaged and papered. Are there just those small things that will make the patient less apprehensive in this very, very challenging time? In the patient holding areas, non-ambulatory, wheelchair, ambulatory, discharge are 4 particular levels that, again, we're going to get them to those areas, we're going to reassess them, and then we're going to make decisions between the evacuation branch director and then, if need be, the transportation director that is then moving people to either a different location within the hospital for returning after an evacuation, or if we're loading up and moving out to a particular area. Just like we would have with a road evacuation, we've ordered the evacuation, we talked about contraflow. We need to have a traffic plan for the hospital. We need to look at the map. We need to say, right, this hallway is a one-way this direction, this hallway is a one-way this direction. If we're moving a lot of patients in multiple directions, we're going to get bottlenecks. We're going to have issues. And particularly outside, we may need a tow truck to be on standby, because what happens if we get an ambulance that's pulling up and breaks down, and then all of a sudden I've got 15 ambulances that are waiting for patients, but they can't get in because we can't move this one ambulance. So thinking ahead of some of the unique resources that you may need is certainly vital in a hospital evacuation. The non-ambulatory loading area, again, we're going to have acuity level divisions that allow us to further sort the patients. So we're going to have low, moderate acuity, critical care, interrupted procedures, arm carry patients, how we can move them, so not only their individual level of acuity, but the resources that are required. The emergency room may be a best place. Again, you know your facilities best, but where in fact would you use this for your non-ambulatory loading area? transfer points to ambulances, helicopters, again, the mass casualty bus, the healthcare buses. One of the reasons why the emergency room is traditionally suggested is because there's an ambulance loading and unloading area. So rather than the ambulances bringing the patients to the emergency room, the loading area is loading the patients into the ambulance from the emergency department. We may look at the staffing situations. Certainly, the emergency room staff, nurses and staff are used to these kinds of things. It may be appropriate to include the ICU and the critical care team from the standpoint of, again, looking at the complexities of the patients particularly involved. And in this particular case, the patients are going to have red wristbands based upon our form of transportation identification. A wheelchair loading area, we need to obviously have an abundance of chairs. We need to reuse those wheelchairs whenever possible. They will become valuable resources. So while we're moving patients, we don't want them to take the wheelchair with them, if at all possible. So we want to hand that off so that we can keep the wheelchairs to continue those transfers. We may be looking at the wheelchair vans, handicap buses, or ambulances. We may be able to get more than one patient in an ambulance if they're in a wheelchair situation. Obviously, we're going to have that holding area, and in this particular case, our patients would have yellow wristbands based upon our evacuation protocol. The ambulatory loading area is going to be a larger area. It may be the same-day surgery entrance. It may be a department waiting room. We're going to try to have as many chairs as we can. We're going to staff it as we would the holding area. And then we're going to move the ambulatory patients to buses and vans. And the ambulatory patients, in this case, on our evacuation protocol scale, are going to be green wristbands. We're going to have a discharge loading area. So this may be the main lobby, or it may be one of our annex buildings. We're going to be able to then transfer from this particular location to a private vehicle, a family member's vehicle. We may use buses or vans in this particular case. And patients may have multiple wristbands in this particular case, where we've addressed their mobility, their discharge, and again, then in our system, they would have a blue band identifying them as a discharge patient. Special evacuation challenges. Again, Lisa mentioned one of the pictures from Hurricane Harvey was a NICU evacuation. Certainly, anyone that's been involved with any type of neonatal transport, boy, there's a lot of equipment with key personnel. So we're going to have additional planning. So in this particular case, not only where are we going and the obvious questions, but also how are we getting there. So can we get this into every type of ambulance? No. There are some ambulances that we would prefer to use just based on the configuration. We can't just move this equipment as readily available as we would others. Our obstetric patients may need some additional planning. Again, depending on where they are, where we are, we need to provide for them care. Burn center patients, again, not only the equipment, but the discomfort, everything that comes in line with that, we need to be concerned. Trauma patients, bariatric patients, and then if we have isolation precautions. If there's isolation precautions, they still have to be maintained during this evacuation where possible. So this may require additional planning. Where do all of the ambulances come from? The ambulances are going to be, obviously our first call is our usual resources, our city, our community, our jurisdiction. But there are a number of mutual aid agreements that our public safety professionals have in place where they can immediately call for backup. But we also have contracts with private ambulances, private handicap van companies, etc. We may need air ambulances. We may need those neonatal transports. These are things that we should have identified in our plans so that we can activate those as necessary. Again, back to our timing of an evacuation, these are very important. So ensuring that we have the appropriate time to launch those contacts and launch those agreements is critical to make sure that we get the appropriate resources at the appropriate time. Be prepared to think outside the box during a hospital evacuation. Again, these are interesting pictures, but it works. We may have trucks or high-profile vehicles. We may have rope chains of individuals that we walk out together holding hands. There are different types of ways in which we can do this, but we need to be thinking of that. We need to think of a security plan for the building, that if anyone does remain, what is the security plan? Unfortunately, we saw some negative impacts during Hurricane Irma. And then certainly one key element that is typically addressed and assessed is what are our pharmacy shutdown procedures and plan? What, in fact, do we need to do to secure the pharmacy and other key areas within the hospital infrastructure? So what do I take away from this time today? What should you do? Where should you go? And this takes us back to our objectives. So ending with our objectives to make sure that we look at the evacuation decisions, the activities, the timeline. We understand what an evacuation is. We look at our evacuation scales, our severity. We look at what are the alternatives to evacuation. Is evacuation always the best case scenario? What are the different types of evacuation? What are the trigger events and the event consequences when we do make that decision? What are the timing impacts that occur? We see how important and how valuable and interdependent they are. How do we best use the hospital incident command system to support our institution, our organization, and our facility during that evacuation? And what are those tactical operations that will lead us to a successful facility evacuation?
Bob, thank you so much. This is Lisa coming back in. That was an amazing presentation. Thank you so much for sharing all of that information. And I do just want to say thank you again to Leonard. Even though he can't be with us today, he is definitely here in spirit. So thank you for bringing that forward. I'm going to just switch. Before we get into the questions, I'd like to take 90 seconds of your time and just go over what happened at Everbridge for Hurricane Irma. We're just using them as an example, but we've been involved in all of the hurricanes this year. That 5-day period, there were over 18 million messages that were sent through the Everbridge platform, almost 5,000 unique notifications. The state of Florida, with their Florida Alert program, is based on the Everbridge platform, and they were sending out a myriad of different messages, first responders talking to each other, but they were also sending out community messages about flood alerts, evacuations, you name it, they were sending it out. We did create the keyword last year for Hurricane Matthew, hashtag FLPrepares. It's a text messaging system that you opt in. We had, between the course of the hurricane, we had almost 1 million people opt into that. And one of the great things about our system is that you can also do it zip code specific. So they opted into the hashtag, but then they also could opt in on a regional basis. So if there was an evacuation order in Miami, the people in Jacksonville didn't get it. So that's something that can be very powerful. We had, I kind of want to bring your attention to that upper right. We had 12 people, 12 different organizations, 72 hours before Hurricane Irma came ashore, asked us, like, oh my God, can you please help us get up and running so that we're protected for this storm? One of those 12 systems was a hospital, and we were able to get them up and running and on the system. I will tell you, one of the great things about working with Everbridge is we really do care about you guys and making sure that everybody is safe. And because of that, we increased our system capacity. We had additional staff on board to help with technical support, network operations center. Those are the people that assist sending out calls. If you call in, we answer every phone call within 30 seconds, guaranteed. During the course of the hurricane, even though we had 2.5 times the volume of requests, we were still able to maintain all of our normal response times. So there was a full court effort around here to make sure that everybody was safe. Despite the fact that Hurricane Irma was so impactful to the southeast, there was a lot of stuff going on that week. Only 29% of our overall volume that week was around Hurricane Irma. There were also wildfires in the northwest. We had several hospitals that were sending out code alerts on a regular basis. There was some cybersecurity breaches, and the earthquake in Mexico. All of these huge, big things were happening simultaneously, and we were able to handle that volume. So with that, I'm going to go right into the questions. Bob, are you ready?
I am ready.
Okay, I'm going to start. Oh, gosh, lots of questions. When in evacuation does an altered standard of care kick in? This might, for example, change the expectation on isolation precautions.
Wow, that's a great question because it's to the root of the best intentions for the patient under the best circumstances. So certainly we need to consider the specifics around a scenario such as that, and then plan for those unique situations as they pertain to evacuating, packaging, communications, all of the elements. So I would apply all of the elements in that particular case, and then it's going to be a case-by-case situation. Include the hospital incident command system if there are some medical or ethical decisions that need to be made. Ensure that you've got good cross-sectional communication and make the best decision under the circumstances.
Thank you. I'm going to dive right in. Thank you, everyone, by the way, for sticking with us. We are going to answer your questions, so we will be taking a little extra time than we normally do. So the next one up is, how do you handle locked behavioral health populations in hospital evacuations?
Lost?
Locked. My apologies. Locked.
Oh, sorry. Locked. Yes. So in the particular case of a locked behavioral health unit, obviously it's going to be resource intensive. So we can still hopefully with a generator backup if we've lost power, we can still have some sort of compartmentalization or some sort of isolation from the standpoint of location, but it may be more resource intensive that we need either additional staff or support personnel to move those patients to either a holding area initially or longer term, or we may need a particular type of transport vehicle. We may have to use other resources to appropriately transport them and continue to protect and serve them.
Thank you. Moving on, so how would you develop a memorandum of agreement with facilities in case of an evacuation, receiving facilities if your facility needed to evacuate?
Great question. Doing it in advance is so important because, again, it's not necessarily the all or nothing scenario. It may be that while you have the agreement in place, the agreement is certainly going to be about all the aspects of business, legality, finance, etc. In practicality and in operation, it's going to be about using those resources to transfer. Maybe it's the critical patients, or maybe it's the ambulatory patients, but communicating in advance with partner facilities, having a discussion about what your mutual plans are. Conducting an exercise is something that I always recommend. That sounds like a lot of work, but exercising both facilities will go so very far when and if that scenario were to occur. So making the contact ahead is really the critical point, and from that point forward, put a cross team of experts together, look at what the opportunities are, and having that plan is only going to help you down the road.
Thank you. We did get a couple of questions around this, so I'm combining a few people's questions. How do you go about working family reunions, reuniting patients with their loved ones, or even if you have more than one patient in a building and they have to go to separate facilities? How do you handle that?
So the information to the families is important. Again, however best that you can do that within your system, whether you have a call tree, whether you have whatever your systems are to be able to do that. And then, for instance, in some of the cases, you may be in a holding area. So I use the hospital lobby as an example, but it may be that you're using a suite, a conference room suite, for instance. Maybe it's a massive conference room on the 7th floor, where in fact you've moved that first and second, or the ground and first floor, away from the floodwaters. It may be that you're in holding for a longer period of time, and you can reunite the family members and the patients in that holding area, or to communicate with the family members and let them know which facility they're going to, and where they can make contact. I draw a similarity here where if we had a school evacuation, that obviously where the child is going to which other school, we would contact the parent to let them know. Same case, just let the family members know what your intentions are, and they can reunite at that point.
Great. And do you mind if I add to that a little bit, Bob?
Sure.
There's a couple of other options you can do. For Everbridge, if you have a keyword like FL Prepares, you could have a specific keyword for your facility, and that's something that patients and their loved ones could opt into, and you would have the opportunity to advertise that to the community before the hurricane comes on shore. The other thing that you can do is have a Facebook page or a blog or Twitter where you're putting that information out on the internet and people can kind of opt in that way. Everbridge allows you to do it from inside the platform, so you also have the documentation in place after the hurricane is over, so you can do lesson learned, but also do reporting to the governmental agencies that you'll need to report out to. Okay, so with that, I'm going to wrap everything up. I'd like to finish with one more comment, if I could. It's from Amy. Thank you for this extremely informative educational webinar. This is the best webinar I have ever attended. Thank you, Bob.
Oh, wow, great, thank you.
I thought you'd like to hear that. Thank you so much. We will talk to you soon.